paper, our own Zohar Rubinstein, who is distinguished first by being co-organizer and originator of this formidable conference, but he has many other accomplishments. He is the founder of the interdisciplinary master program for emergency and disaster management in the Tel Aviv University Medical School. His PhD at the Tel Aviv University is entitled From Shell Shock to Combat Reaction, the History of Parallel Transitions in Yom Kippur Lebanon Wars as expressed in the Therapist and Mental Health System narrative. And he's also the originator of the model and design of the model for the treatment of acute stress reaction casualties under missile bombardment that occurred in the Lebanese Second War, which was recently published and has been adopted as the national response for such events. And I think it sort of puts Zohar just in the very core of what Israel is living through about and experiences. Now, the title of this presentation is Contradicting Narratives of Therapists in the Yom Kippur War as they emerge from their testimonies.
Thank you very much. As you may realize, I altered the first word instead of contradictory with a softer one, differing, in order to make things a bit easier. The Yom Kippur War was also known as the October War, broke out on October 6, 1973. It is considered the most dreadful of all Israel's war. The toll was very high: 2,564 dead, 6,924 wounded, 300 prisoners of war. The shock of its unexpected outbreak and its aftermath has enormous impact on the Israeli public and on soldiers in both the regular army and the reserves. It was termed as the second Shoah by some and caused severe demoralization, at least at the beginning of the war. The war was burned into the Israeli consciousness as the nation's most traumatic event since its establishment. It has remained such to this day. It was the war with the highest number of combat shock casualties ever. According to official data from the IDF Surgeon General, excuse me, the number of combat shock casualties reached 700. However, according to my historical research, on which I will elaborate shortly, 1,600 combat shock casualties were hospitalized in the different units of the installation especially set up during the war and up to May 1974. According to another source, who has become the head of the research branch of the IDF Mental Health Division, the number was actually 2,800 casualties, 4 times more than the official figure. I argue here that the discrepancy is not accidental and that its root lie in the tendency of the High Command to ignore, deny, and to repress the phenomena, which was, at the time, incomprehensible to the head of the medical corps. The whole of the war glaringly hit the Army's Mental Health Command. There were only a handful of mental health officers in the regular cadre. Many civilians' mental health personnel were called to duty. They were posted on the different fronts, both on the front line and the rear installation, with hardly any knowledge of the phenomena of combat shock, and were barely competent to treat such a complex and enigmatic nosology. In my study, I found that for them, the experience was most traumatic, and that many of them have scars in their psyche to this very day. I should add that some of them are really real PTSD. The description of the mental and cultural arena of my presentation is crucial to understanding the dynamic of the narrative of memory distortion in the testimonies of the therapist. I would like to present 3 cases of such distortion and to suggest some reflections on its occurrence. But first, a few words on the nature of my research. My original research dealt with the discourse of the mental traumas in soldiers caused by war as reflected by the narratives of the therapists, researchers, and directors of the military mental health system in 2 Israeli wars, the Yom Kippur War in 1973 and the First Lebanon War in 1982. The research went beyond the analysis of the written historical materials produced during and after the wars and aimed to understand the historical mental health discourse through an understanding of the worlds of the therapist and the directors of the mental health system involved. This understanding, which also take into consideration their emotional world, shed light on the way they conceive the phenomena of mental trauma and its origins, as well as the method of treatment they employed and their subjective evaluation of the outcomes. It also enabled to determine how emotional aspects influence their perception, activities, and decision-making processes during the wars. Thus, an initial source of material was introduced into the analysis of the historical discourse, the narrative, whose subjective characteristics were emphasized by Michel Foucault, The Archaeology of Knowledge in the Discourse of Language, which he published in 1972. Reconstruction of the narratives of the therapist, the heads of the mental health system, as well as their researchers, has the potential to achieve a rich fabric of historical material interwoven with its written and spoken texts. The confrontation of the various sources and the analysis of how they correspond with one another enables a wider historical picture of what actually happened in the mental health realm during the 2 wars. Due to the lack of sufficient written sources from the Yom Kippur War, which is itself a reason for research, and the wish to enrich the historical picture with narrative-based source, the oral history method was employed. The method involved interviewing the therapists and directors of the mental health system at the time, so transcribing the interviews and analyzing them through the narrative analysis. During the interviews, especially with the Yom Kippur War interviewees, some of them presented me with written material, notes and tractates that have never been published, thus enriching the written sources. In addition, in 2004, I initiated a conference in honor of the therapist of the Yom Kippur War, whose purpose, in addition to paying homage to their work during the war, which was never done before, was to uncover additional themes in the history of the therapist that had not found expression in any other medium. In the salient themes, the salient themes of anger and guilt appeared in the epiphenomena of deeper and no less difficult emotions which influence the therapist's perception and construct their experience. I will illustrate some of these in my presentation. I called the first case, Was the Pie Really There and Then? And I will use the presentation just for the quotation of the interviews. Thomas Salmon, sorry. There is no connection between. Sorry. I just realized there is no connection between some of the. So I'll manage. No, it's fine. Thomas Salmon, a young American psychiatrist who visited the French front during World War I, was the first to formulate the 3 principles of frontline treatment of mental health war casualties in 1917, later restated by Artis in 1963, and known as the proximity, immediacy, and expectancy, in short, PI. That is, soldiers who suffer from combat stress have a better chance to returning to duty if treatment is given very close to the battlefield without evacuation to the rear, if they receive the treatment as soon as possible, and finally, if the therapist transmits the message that the phenomena they are experiencing is merely a reaction, which is very likely to subside if they do whatever they needed to resume functioning. This formulation is logical, coherent, and simple to assimilate, and seems to be a very well-known way to assist many. It was forgotten, however, by all armies in subsequent war, and the IDF's mental health leaders only rediscovered it in 1978. It gradually became the doctrine of the mental health response, reaching its climax during the First Lebanon War in 1983. Almost all the therapists I interviewed for my research testified that they knew the PI principles and worked according to them during the war. I said Yom Kippur War. What they knew and cited were Salmon principles which were known then. This was the protocol. I don't know if it was someone's doctrine, but the army determined that the therapist came, treated according to Salmon, and sent them back. The commanders of the Army Mental Health Division, whom I interviewed at that time, said the same thing. Look, we knew the concept of Salmon, proximity and all that stuff. What was not applicable and what we didn't understand was that Salmon said that one should treat those people within the range of the bombing. But in Israel, 60 kilometers is far, so there was great confusion. Here, one can see a learned discussion regarding the applicability of Salmon's PI. However, a careful examination of all the articles written by therapists on the Yom Kippur War and published between 1974 and 1979, including an article by one of the commanders I interviewed, shows that not a single writer ever mentioned or cited Salmon. This is in contrast to vast citation of him immediately after the Lebanon War. How can this dilemma be explained? 2 options can be offered. One, that Salmon's principles were known then, but for some strange and inexplicable reason, they were not mentioned in the literature. Or the second, the knowledge was not accessible at the time of Yom Kippur War, and only later, following the dissemination of the frontline treatment doctrine, especially between 1979 and 1985, did therapists became aware of the PI post factum, and it was experienced as known during the Yom Kippur retrospectively, as if it had been there in the first place. I argue that the second option is the valid one. The distortion in memory is well known in oral history, especially when bearing in mind the time gap between the war itself and the interviews. But deeper reasons can be considered as well. The first, overt one, might stem from the indoctrination of the Salmon principle in the years to follow, and then the fact that PI has been canonized as the leading concept in frontline treatment. It has been taught and assimilated in all mental health drills to the point where there is no possibility, as they say, that we didn't use those principles. The other, perhaps more latent reason, is an unconscious response to accusations by the public regarding the failure of the treatment of combat stress casualties, which was actually, unfortunately, the case. There was a failure. A narrative of guilt may well be the generator of this memory distortion. The second case I called the disciple against his master. The lack of knowledge during the war created a vacuum which, in the stress conditions of war, had to be filled. Lacking instructions and guidance from the head of the army mental health system, therapists began to consolidate around those who before the war had already been respected for their mastery of methods or approaches to treatment which seems to be most applicable to wartime. Such was Dr. K, who gained a reputation for hypnotic virtuosity. K established a frontline station in the south and at the beginning of the war and soon became a guru for treating combat shock casualties by the dozens. At the beginning of the war, the central treatment in that station, which gradually became widespread, was abreaction, namely the release of the emotional and cathartic load by relieving the traumatic experience by means of either hypnotic or suggestive inductions, or later by injected pentothal sodium, also known as a narco-analysis. After the war, the abreaction approach was strongly criticized and eventually was considered as one of the approaches that deepened the trauma and further established the PTSD. One of the psychiatrists who worked with Dr. K's guidance was Dr. A, who in 1974 published one of the few papers on that war. Actually, only 6 papers were published. Very strange. He didn't ask his mentor to join him in writing the paper, which included serious criticism of the method used, in itself standard practice among professionals who do not share the same conceptual approach. In his paper, Dr. A wrote, "Every single mental health casualty, without exceptions, underwent abreactive treatment. The thought that guided us was that the only way to prevent the development of those symptoms and to remove the sting of the traumatic experience was by cathartic abreaction." In contrast, in the interview with Dr. K, the guru, he said, "Our principal method was abreaction to release the emotion parts, and after that we held discussion groups in order to process the material and give supportive therapy. But I did it only several times, not all the time. If too many abreactions were conducted, they, the soldiers, created reconstruction out of them. When they saw you, they started to run on abreaction, which was no good." From the perspective of 30 years after the war, the time of the interview, Dr. K stated that he realized then that abreaction should not be excessive and that there was great importance to continual working through because access could result in fixation among the soldiers and prevent them from recovering from trauma. The memory distortion in Dr. K's testimony can be explained by the process of renunciation of the consensus held during the war. The abreaction is the state of the art. This was the consensus. The abreaction was the state of the art. The narrative of this change was demonstrated at the conference in 2004 when one of the most distinguished figures in the Israeli psychiatry made the following statement. "I really believe that at that time that I was doing the right thing. But today I know that I wholeheartedly admit that what I did then was not right. I am saying this today because that is what I really think today, and it is not what I wanted to teach the following generations. One should not dig deeply inside or stick it harder than it is already stuck, because it hurts and I cause more pain. And anyone who studied those soldiers today can verify that what I'm saying. I did not know if then, but one should know how to say I'm sorry. I thought that those principles upon which I was educated in the psychoanalytic school, and then the abreaction which stems from it, them was vital and essential for the future of mental health of the wounded. The third case, and the third and final case, I call the story of two wards. Beit Nissan was one of the main army installations for the treatment of combat shock soldiers in the central part of Israel. It was established to answer the needs of those who had already developed prolonged reactions, where the syndrome gradually began to have PTSD characteristics. The installation was held by Dr. F, an ophthalmologist who was somewhat detached from the atmosphere of the place and was a rather colorful figure, as I'll demonstrate shortly. The installation consisted of two wards, A and B, under the command of two leading and dominant figures well known in the field of psychiatry in Israel, who also refer to conflicting approach to the treatment of combat shock. I said again, also reflected to conflicting approaches to the treatment of combat shock. Ward A was held by Dr. D, whose approach was dynamic and who believed in the modality of psychotherapy, both individual and group. His team consisted of 13 therapists, 3 psychiatrists, 8 psychologists, and 2 social workers. In sharp contrast, Ward B was headed by Dr. L.K., the leader of narcoanalysis at that time, and with him were 20 therapists, 5 psychiatrists, 7 physicians, 6 psychologists, and 2 social workers. The focus of the treatment in Ward B was active narcoanalysis intervention to create a reaction by injection intravenous pentothal sodium combined with intensive desensitization. While being the infusion or injection, soldiers were exposed to tapes of combat noise, including bombardment and jet fighters, so to evoke the combat atmosphere and to allow a reaction. Other medications, such as antidepressants, were administered as well. After this process, group intervention were performed with participants of both wards by psychologists from Ward A. Words cannot describe the rivalry between the two ward commanders. The intensity of their hostility, as reflected in their testimonies concerning one another, was far beyond the professional level and clearly very personal. Listening to the tapes of their testimony, I had the impression that time for them has frozen, and I suspected that deeper intrapsychic issues were at stake, and not only personal rage, envy, and animosity, and that these might reflect a secondary traumatization syndrome. Before focusing on aberration of perception that occurred in the two departments, I wish to illustrate the surrealistic atmosphere that prevailed in that installation as it emerged from one of the testimonies. In May 1974, there was a parade in the installation to celebrate Israel Independence Day. Dr. F, the installation commander, shining in his uniform with its decorations and medals, reviewed the lines, holding a baton like an officer of a foreign army. Suddenly, he approached one of the officers, a captain, whose rank emblem was attached to his shoulder, strapped with a safety pin because of a missing button. The commander took his baton and with a quick movement tore the emblem off, and it fell down. There was a moment of silence, and then suddenly shouting burst out. Dreyfus, to reflect this very sad occurrence in the history of Israel, anti-Semitic. Dr. F, realizing what he had done, turned around in the middle of the parade, fled to his room, and didn't show up for 3 days. Two narratives emerged from my interviewing testimony regarding their perception of the severity of the patient's condition. The first was held by Ward A team, the dynamic team. According to them, the population in the two wards was the same, with a similar severity of symptomatology, and the difference between the wards was the result of the different therapeutic milieu. On the other hand, Ward B team members were convinced that they had received the most severe cases, soldiers who were originally triaged to them because they could not respond to psychotherapy. Hence, the milder cases were admitted to Ward A. Let's look at some of the testimonies. Undoubtedly, the severe cases were sent to us. They were severe ones come to us. The light cases who could do psychotherapy, who could talk, cooperate, who were, how to say it, dystemic, were sent to them. It was different group altogether. We got the hard cases. You could not open them at all. The only way to reach them was through abreaction. Or you could walk around the installation and immediately identify those whose patient is who, according to his appearance. At least in the first period of hospitalization, our patients were totally burned out. They looked chronic. But one night during a thunderstorm day, the soldier in Ward B got out of bed scared to death. I asked, and yours didn't? I asked, of course, Dr. D from Ward A. No. Or, our guys were people who didn't have any connection with their surrounding at all. They could sit in a group and talk about their grandmother. Sorry, they couldn't sit in a group and talk about their grandmother. All the hardest cases came to us. A paper published in 1978 by one of the psychologists from Ward A compared the two populations and discussed the two milieus. This written testimony sheds fascinating light on the debate. Note the writer rhetoric. Two clinical teams are described in the present paper. They showed complex psychosocial reactions to acutely changing conditions, thereby bringing into existence divergent types of therapeutic milieus. One of these favored pharmacological means of support and abreaction. The other milieu accentuated the psychodynamic aspects of group interactions. Team B, please pay attention, Team B is presented here as favoring pharmacological and abreactive intervention, while Team A accentuated psychodynamic aspects. And further on, the neuropsychiatric model with authoritarian tendencies, and two, the social model characterized by an egalitarian approach, which often fosters therapeutic innovations which became acceptable under unusual conditions where previously accepted clinical traditions do not provide ready answers. Here, the pharmacological world is presented as having authoritarian tendencies, and the other is as fostering an egalitarian social approach. Tendencies versus approach, authoritarian versus egalitarian. I wish to argue that the choice of words is deliberate and coincides with the general atmosphere that prevails in Beit Nissan, and that the negative bias toward Ward B fostered by Ward A. There are other problematic aspects in the article which I will not discuss here, especially concerning the issue of whether the two populations were the same in terms of clinical evidence, as the writer claimed. What we have here is clearly a Rashomon effect. In a newspaper article published 27 years later, one interviewee said, "In principle, Dr. D and Dr. LK did the triage. We, Ward B, would receive the worst cases, while the others who could talk and express themselves went to A." The reporter asked him, "Why was that?" And his answer, "Honestly, I don't know. I believe there was a good reason." In contrast, Dr. D testified in the same article. The triage of soldiers to Ward A and to LK's ward was absolutely coincidental. In the absence of solid clinical data to support either argument, we cannot but assume that we have two contradictory narratives which, in light of the fact that many prominent therapists, well versed in the art of diagnostics, are involved, present us with something of an enigma. Time constraints prevent me from attempting to explain the enigma in full, but I suggest that since most of my interviewees underwent a traumatic experience while treating the soldiers, many issues, both emotional and ethical, remained unsolved. Hence, conscious and unconscious correspondence with guilt had a significant influence on the memory distortion or aberrational perception of reality. For example, and here comes to the end, I found that the Ward A team enjoyed great cohesiveness and teamwork in comparison to Ward B. One can assume that this was because they felt that they were doing a wonderful job and wished to view the outcomes of the treatment as a direct result of the hard work they invested in the soldiers, and not because they got mild cases. In the same way, the Ward B team must have experienced many failures and frustrations and wish to view those results in the light of the severity of the cases they receive and treated. This example demonstrates the emotional and motivational components, together with the passage of time, influence the perception of reality, even the clinical reality, and how the therapeutic approach and stressful interpersonal relationship can result in reconstructed narratives which tell us different and even contradictory stories. Thank you.
Thank you, Zohar, for bringing us back into history, but also back into the present. I would like very briefly to add something. I joined the Yom Kippur War on the 5th day and was stationed in the north, Machanaim, probably not that far from the front lines. We had no clue about the Salmon principles. Nobody told us. And, pardon? Yeah. And what I observed was that the worst casualties were children of Holocaust survivors. So the approach was to reconstruct the connections of the absent voices, of the shadows, not to abreact. And we did not use abreaction. The one time I used hypnosis, I had bad results. Please, questions?
It's fascinating. It would seem that there might be an opportunity by reviewing archival records or interviewing soldiers, former soldiers, to answer some of the questions that you have posed. Have you thought about that or considered consider doing that, or are there obstacles to doing that? And also, you raise a lot of ethical questions you didn't speak to about the rights of soldiers concerning treatment. I wonder if you could address that.
Two difficult questions. The first one, there are many obstacles because all those poor casualties from Yom Kippur War, which is already from 73, are under the treatment of the veterans authorities of the army, and many of them are in very poor conditions, and I'm afraid many of them cannot be interviewed anymore, and I have doubts about the authenticity and validity of the material that I would get in nowadays. Now, the ethical is a great issue. I don't think we have any answer to it, because in a time of war, usually we use the best practice, and it was believed at that time that abreaction and narcoanalysis was the best. This was taken straight from World War II, when Grinke and Spiegel, if you heard those two figures, influenced the whole world of treating combat shock soldiers, because they gave a test. They wrote a book in 1942 in which they praise this treatment. I just want to say, I told one, in my research, I made a thorough analysis of their text. Simply, I read carefully the book. And to my great astonishment, I realized that there is when you really read it, I don't understand why this method was actually adopted in the first place, because what it says actually is that it's a lousy method. Although in the cover page, in the front page, there's a praising letter from the Major General of the American Air Force. Very strange.
Another question about a maybe related ethical issue. Is it considered an ethical issue, maybe the question of the fact that many of these methods or treatment methods are geared at the quick return of soldiers to the front, meaning that it isn't necessarily, or maybe I'm asking, it isn't necessarily long-term mental health in mind, or is it more practical in terms of getting soldiers back to the front?
Okay, this is a very important issue, and I wish to elaborate a bit. Well, I admit at the beginning the army actually used this phrase, as was in the wars, in the two world wars and Korea and Vietnam, is to return to battle. But from the 80s, after Lebanon War, it was altered. And the issue is not to bring him back to battle as soon as possible, but to bring back to functioning. And this was a major change in the ethical approach, because then the mental health officers join the battle of the soldier to regain some kind of help. And when this was changed, it was even more for the combat, from the mental health officers, it was for them, especially for the reserves, they start more to agree, and then it has a great effect.
You would address a little bit the orality of your quotations. I'm trying to envision, because you're interested in the language of these quotations, and I'm trying to envision them in Hebrew, trying to hear them in Hebrew, and I hear very high, almost technical language. It could be, usually in translation, people raise the register of language anyway, so maybe it's a form of translation, but if the translation is faithful, I think that there's something in the language of the interviewees that sounds almost not so oral, as if they're trying to distance themselves and their language from the way that they're addressing this question, almost as if they're citing a medical textbook is how they sounded to me. So can you just help me with that?
Thank you. Two considerations are in mind. One, we should remember that I interview a psychotherapist, which means clinical psychologist, psychiatrist, who are, I think, the most leading figures in Israel society up to date. So this is I would say, this is everyday language in a way when they talk to a colleague. However, set ashore that parallel to these kind of formulations, I got a lot of emotional phrasing, emotional words that even shock me while interview them. The kind of honesty, the kind of self-disclosure and revealing of something not flattering statements were as well there.
The last question. Thank you very much. I think we should